volume. So good afternoon, everyone. So we'll be discussing about the emergency medicine. If you see the next CBME, emergency medicine also has an important aspect where you can expect based on that at least like 3 to 4 questions from the emergency medicine. When I say emergency medicine, this includes it includes cardiac emergencies. We'll do that later. This is about cardiac emergencies, respiratory emergencies, neuro emergencies, endocrine emergencies. Then in addition to this, psychiatric emergencies, obstetric emergencies, BLS, ACLS, trauma. All these things come under emergencies. You have like in the 40 questions which have been given, like it's been touched that from every system 2 to 3 questions have been asked. And now let's go back to the questions. It's mostly clinical based. Okay. The first question: a 58-year-old male presents to the emergency department with chest pain, which is retrosternal, crushing in nature, and radiating to his left arm. His ECG shows ST segment elevation in lead 2, lead 3, and AVF. Which of the following is the most appropriate next step in the management of this patient? Options: stress test, cardiac catheterization, immediate thrombolysis or percutaneous intervention, and calcium channel blockers. How many for option 1? Option 2? Option 3? Option 4? See, basically it's a straightforward question. Now, whenever a question, you get a clinical question of this, just see what is this being asked. You have the patient, the clues here in the question is chest pain is there, which is retrosternal, crushing in nature, radiation. It's a typical characteristic description of the MI. And also the ECG showed a ST segment elevation in leads 2, 3 AVF. That indicates inferior wall. And then which of the following is the most appropriate next step in the management of this patient? What do you do? Even if you don't know, how can you answer? Stress test. In a patient who came to an emergency with MI, will you do stress test? Though stress test is one of the non-invasive cardiac tests, you can't do this. And cardiac catheterization. Yes, cardiac catheterization definitely helps in finding out what exactly is the reason, where exactly happened. But at this point of time, immediate thrombolysis or percutaneous coronary intervention is the most important thing. Then you see this, the patient's symptoms and ECG findings. See, I'm going to share this PDF with all of you. So don't worry about this. Focus on what is important. We'll share this PDF with you, including the one which is handwritten with me. Like you'll get this PDF. Just focus. I had given a clear-cut explanations with every option, like why it is correct, why it is wrong, so that you can get an idea. See this. The patient's symptoms and ECG findings are consistent with ST segment elevation, myocardial infarction, STEMI, which is a type of acute coronary syndrome. The management of STEMI involves prompt revascularization. Either you do it with the thrombolysis or percutaneous coronary intervention. Stress test. See, this is inappropriate in this patient who is presenting with an acute MI, particularly to the ER. Then cardiac catheterization. This can provide valuable information, but the immediate need in STEMI is revascularization is very, very, very important. Revascularization you can achieve through thrombolysis or PCI. Again, you have to rule out is there any contraindications for thrombolysis and all. I'm not going to dwell deep into what are the contraindications of thrombolysis and all. You already, whatever the emergencies, what I've been dealing, the detailed aspects of this is discussed in your medicine. I'm just saying in the emergency medicine context of you. Okay. And immediate thrombolysis or percutaneous coronary intervention. This is the preferred management strategy in STEMI. The goal is to achieve reperfusion as quickly as possible. Very important. Then calcium channel blockers, you can use it, but this is not the first line treatment in the acute management of STEMI. Got it? Clear about this concept? So these 40 questions, we will be discussing about 40 concepts and mainly related to the emergencies. Then coming to It's high yield point. See, STEMI is characterized by chest pain and ST segment elevation on ECG. Immediate revascularization through thrombolysis or PCI is the preferred management strategy. For every question, I had given like 1 to 4 high yield points also, which you should not miss about this. Clear about this concept? Then, coming to the second question. A 65-year-old man presents to the emergency department with sudden onset of severe dyspnea and palpitations. His pulse rate is 160 beats per minute and blood pressure is 100/70 millimeters of mercury. ECG shows a regular narrow complex tachycardia with no visible P waves. What is the most appropriate initial management? What is what they are giving? Last week we had discussed about narrow complex, how you manage the tachycardia and all. So what is this basically? What is they being asked here? The heart rate is, see this, sudden onset of severe dyspnea and palpitations are there. Heart rate is 160 per minute, but ECG shows they are regular. Then narrow complex tachycardia, the clues, just try to correlate. Narrow complex tachycardia, no visible P waves. If the same question, instead of regular rhythm, they might have got irregular, then what will be your diagnosis? Very good. Come on. Yeah, atrial fibrillation. But here they mentioned regular and narrow complex tachycardia, no visible P waves. So it is mainly very fantastic. Paroxysmal supraventricular tachycardia. So how do you treat with paroxysmal supraventricular tachycardia? Come on, guys. Adenosine. How do you give adenosine? How much? What is the dose? Very good. Adenosine 6 mg is what you give. When you give adenosine 6 mg, if it won't correct, and there's a push technique. What is the push technique of adenosine? So when you give into the IV, you have to immediately, with the normal saline, you have to push and elevate the hand. Okay. And as much as possible, try to give near the central line if it is available. So if even with 6 mg, if it won't revert, then what do you do? 6 mg, repeat 6 mg, and then you can go up to 12 mg. Okay. So here adenosine is the drug of choice. See here. The patient's symptoms and ECG findings. So here's the symptoms. They're suggesting sudden onset of severe dyspnea and palpitations, and ECG findings, which are regular, narrow complex, and no visible P waves. So all the suggestive of PSVT. The first line treatment is adenosine. So adenosine is a drug of choice for initial management of stable PSVT. It works. How does the adenosine act? It works by slowing conduction through the AV node. This is important. Slowing conduction through the AV node. So tomorrow you might get a question, the drug, all this question they'll give it, how they can integrate with pharmacology is you choose a drug and where does the drug act and how do they act. So that is what you can mention. Then metoprolol. Metoprolol is a beta blocker and is generally used as second line therapy for PSVT. All these drugs, metoprolol, amiodarone, verapamil, all these drugs can be used for PSVT, but they are not first line treatment. Okay. See, this is a beta blocker used as it's generally a second line therapy, and this is also used for second line agent for PSVT. Amiodarone. Amiodarone, where do you use most commonly? When you see any shockable rhythms and those conditions, ventricular fibrillation or pulseless VT, there, what is the dose? Amiodarone, you give 300 mg bolus followed by 150 mg subsequent doses. Then verapamil is a calcium channel blocker and is also used as second line agent for PSVT. This is also important. Okay, this is about the rhythms: narrow complex tachycardia, broad and wide complex tachycardia. How do you do that? Then bradycardia. What are the symptoms? All these things are important. Then PSVT is a narrow complex tachycardia that is typically abrupt in onset and also it terminates abruptly. Adenosine is a first line treatment for stable PSVT. Okay, then a 78-year-old female presents with dyspnea, orthopnea, and lower limb swelling. On examination, she has a raised JVP, bilateral basal crackles in the lungs, and pitting edema of the legs. What is the most appropriate initial treatment? Diuretics, beta blockers, ACE inhibitors, digoxin. Diuretics. What is the diagnosis? You're right. Congestive heart failure, predominantly right-sided. Yes or no? You are getting so many clues. Dyspnea is there, orthopnea is there, lower limb swelling, that is pedal edema is there. She has raised JVP, increased JVP is there. An auscultation, bilateral basal crackles are there. Pitting edema. So in this, how do you treat this? Basically, congestive heart failure, how do you treat this? How many for diuretics? Lift your hands. How many for beta blockers? AC inhibitors? Digoxin? What's your name? Okay, you're correct, but partly if one word I will add in the question, if I would have added one word in the question, the digoxin would have been the correct answer. If the same patient if also has atrial fibrillation or any rhythms, like then your digoxin answer might be correct. But in this particular context, particularly you have to you have to remove that fluid, and for that you have to give the diuretics. So these patients and symptoms are suggestive of congestive heart failure. The mainstay of initial treatment in these patients is to reduce the fluid overload with the diuretics. That is very important, to reduce the fluid overload. And diuretics is the most appropriate initial treatment with patient with symptoms of fluid overload due to heart failure. It helps to reduce the preload and thereby helps in decreasing the symptoms of this dyspnea orthopnea. If you see this AC inhibitors do you use in heart failure or not? You use, but they help predominantly in they act in afterload rather than the preload here. And beta blockers, while they are also can be used for management of heart failure, they are never a first line management. Then AC inhibitors, they can also be used, but their primary use is to decrease the afterload and not to control the acute symptoms. So AC inhibitors mainly acts to control the afterload. Then digoxin, this is used in the patients with the heart failure and the atrial fibrillation. This is important. Are in those who remains asymptomatic even with other drugs. You use digoxin, you use diuretics, beta blockers, AC inhibitors. Even with this, if the heart failure is there, still you can go back to that. Here, in this particular context, what are the 3 points you have to remember? One, how can you identify the heart failure patient? This is most important thing, okay, based on the right heart failure and based on the clinical features given. Then what is the first drug? Diuretics you use. Then what is the second line of treatment what you can use? Then what are the drugs you can use to decrease the afterload? Where does the diuretics add? Where does the diuretics act? Then digoxin, in the same question, if they add one extra point of atrial fibrillation, you can think about digoxin. Clear about this? Yes or no? Then the mainstay of initial treatment in heart failure is with fluid overload is diuretics. Beta blockers and AC inhibitors have a role in the management of heart failure, but are not the first line treatment in the acute setting. Clear, guys? Yes or no? So these are like a few things when compared with the chest pain, rhythms, arrhythmias, congestive heart failure. These are predominantly the cardiac emergencies which you should be knowing about this. These 3 concepts, particularly from cardiac, we'll discuss about BLS, ACLS latter part of this. So anything related to the rhythm, how do you manage this? And what are the 2 shockable rhythms? Ventricular fibrillation and pulseless ventricular tachycardia. Non-shockable rhythms? Asystole and pulseless electrical activity. So at least there are few rhythms which you have to identify, even if they give an image-based question. Obviously, asystole you can identify, sinus rhythm you can identify. There's no need to spend hours together on ECGs to give and get minute points. There are like 10 to 12. Just focus on this sinus rhythm, and then asystole. These 2 though, like you can anyhow identify. Then coming to ST elevation MI, atrial fibrillation, ventricular fibrillation, ventricular tachycardia. Okay, and then coming to S1Q3T3. What is S1Q3T3? S1Q3T3, where it is? Pulmonary embolism. We will discuss about this rhythms. And then coming to atrial flutter, then knowing about this PSVT components, narrow complex tachycardias. Then obviously you can identify about this bradycardias. And if you can remember at least these things, 70% of your ECG questions will be covered. At least, like by spending the daily 10 minutes, you can spend on these things and you can master those things. But if not, you can't, if you can't go and read about every ECG, at least master. First target is keep 10 to 15 ECGs where you are confident about, then you can take it forward. Okay. This is about cardiac emergencies, predominantly about heart failure. How do you heart failure, the diagnosis and the management of heart failure, various rhythms and how, what is the immediate stay of management. Then coming to the chest pain with, what are the other differential diagnosis and how can you identify? Okay, these are important. Then coming to respiratory, a 68-year-old man with a known history of COPD presents to the emergency department with increasing breathlessness and productive cough over the past 2 days. On examination, he is tachypneic and there are decreased breath sounds and prolonged expiration. His saturation is 88% on room air. What is the most appropriate initial management of this patient? See, how many for supplemental oxygen? How many for inhaled corticosteroids? Antibiotics? Non-invasive ventilation? See, the thing is, all the 4 options are correct. Like for some other patients, you can keep using all these things depending on the patient situation. In this particular context, what is correct? See, what is been given asked? He has a known history of COPD is there, with increasing SOB is there, productive cough for the past 2 days. On examination, there's a tachypnea, decreased breath sounds, and expiration is prolonged. In addition to this, saturation is 88%. What is the most appropriate initial management is being asked here. So supplemental oxygen, inhaled corticosteroids, antibiotics, non-invasive ventilation. So here, this patient might be having the COPD patient, they might be having acute exacerbation. Okay, all these things you can use inhaled corticosteroids, antibiotics, non-invasive ventilation, but at this particular context, in this thing, the patient should not go into hypoxemia. You should administer supplemental oxygen. See, the patient's history and examination findings suggest an acute exacerbation of COPD. In such patient, the initial management should focus on correcting hypoxemia with supplemental oxygen. Similarly, the similar question, if they say like the patient is having a high-grade fevers and the purulent cough, the cough with purulent sputum is there, and all those conditions, administering antibiotics also become equally important. And non-invasive ventilation, you go when the patient is still not maintaining the saturations, or like when the patient needs additional support, you can use non-invasive ventilation. So hypoxemia is a common feature of acute COPD exacerbations and should be corrected immediately with supplemental oxygen. Inhaled corticosteroids, they can definitely reduce the inflammation in the airways, but their role in initial management of acute COPD exacerbation is always secondary to oxygen therapy. Antibiotics, they are generally used in patients with COPD exacerbation who have, as I told, sputum purulence or volume, or those who might be requiring mechanical ventilation. You can still use, but again, you have to say which is your initial management therapy. The non-invasive ventilation, this is beneficial in patients with severe exacerbations characterized by respiratory acidosis or respiratory failure, but not in all cases. See, when you take an ABG, when you see this patient's pH is 7.2 or 7.3 and PaCO2, when carbon dioxide is accumulating, it is going up to 65, 75, then you can use the non-invasive ventilation. Clear about this? Yes or no? Then acute exacerbations of COPD are often associated with hypoxemia. Supplemental oxygen is the most important initial treatment of acute COPD exacerbations. What is the answer here? Supplemental oxygen. Then a 25-year-old female presents to the emergency department with sudden onset of shortness of breath, pleuritic chest pain, and hemoptysis. She recently underwent a surgery for fractured femur and was immobilized for a few weeks. Her heart rate is 110 breaths per minute, blood pressure is 100 by 70 millimeters of mercury, and respiratory rate is 24 breaths per minute. What is the most likely diagnosis? Acute asthma attack, pulmonary tuberculosis, pulmonary embolism, pneumonia. How many feel acute asthma attack? How many feel pulmonary tuberculosis? How many feels embolism? Good. Pneumonia? So why can't it be acute asthma attack? Or tell me, as you said, like pulmonary embolism, what are the factors that are in support of acute pulmonary embolism? Sorry? Surgery for fracture femur, very good, and was immobilized. That itself is a predisposing factor for DVT. Okay. Then sudden onset of shortness of breath, sudden onset SOP, pleuritic chest pain, hemoptysis. And see, but the vitals are like, though they have tachycardia and minimal hypotension, in embolism, if it is worse, it will further decrease. There will be rapid decrease in the blood pressure also can see, and you can see rapid decrease in saturation, and even in the severe cases, you can see the fall in saturation also. Did we discuss somewhere today regarding embolism? Capnography, in capnography waveform, they look rapid decrease in ETCO2 will be there. Okay. Now here, just think about that. Acute asthma attack. In acute asthma attack, also the patient may be like with the anxiety, they might be having tachycardia and respiratory rate may increase, and sudden onset of shortness of breath might be there. And but pleuritic chest pain and hemoptysis are against this. Yes or no? And the clinical relevance of surgery of fracture femur immobilized, they won't fit into this asthma attack. Then pulmonary tuberculosis. See, the age is suiting that 25-year young females are more common for tuberculosis. That is there. But will you get sudden onset of shortness of breath? No. What are the cardinal features in tuberculosis? Cough with sputum. Evening rise in temperature will be there. Night sweats will be there. So all these things are not in the clinical context here. And hemoptysis also not fits this. Then coming to pneumonia. Pneumonia, again, what is contradicting? Sudden onset of shortness of breath is contradicting. Pleuritic chest pain, hemoptysis. They didn't give any fever, or like, it's not mandatory that all pneumonias have fever, but again, which is they didn't mention about that. And surgery for fracture of femur. So just think, for when you are pretty sure about that option, also check for another like 5 to 10 seconds. Like, you can also, is there any another deviating point or that, and then you can go ahead and answer. So as that, the patient's symptoms along with the recent history of surgery and immobilization make pulmonary embolism the most likely diagnosis. Pulmonary embolism commonly presents with sudden onset dyspnea, pleuritic chest pain, and hemoptysis. So acute asthma attack, this would typically present with wheeze, chest tightness, shortness of breath, but not with the hemoptysis. See, the reason why I'm giving you detailed explanations is, in the next examination, what I'm going to do based on the options here, I'll be framing another questions like those. So those are the way, this is how you can get the questions right. Tomorrow you may get a question based on acute asthma attack. Okay, this wheeze is characteristic, chest tightness. Okay, then pulmonary tuberculosis, this typically presents with the chronic symptoms such as we discussed, weight loss, fever, night sweats, and the hemoptysis may be there sometimes, but not with acute onset dyspnea and pleuritic chest pain. Then coming to pulmonary embolism, this is the most likely diagnosis given the patient's acute symptoms and the recent risk factors such as surgery and immobilization as discussed by us. Pneumonia, this generally presents with fever, productive cough, and dyspnea, but the patient's recent risk factor makes pulmonary embolism more likely. Clear about this? And as discussed, pulmonary embolism often presents with sudden onset dyspnea, pleuritic chest pain, and hemoptysis. Recent surgery and immobilization, they themselves are significant risk factors for pulmonary embolism. I'm not going to list out all the risk factors for pulmonary embolism and all. Then coming to next question. A 50-year-old man presents to the emergency department here with sudden onset of severe chest pain and dyspnea. On examination, there are decreased breath sounds and hyper resonance on the right side of the chest. Blood pressure is 100 by 60 millimeters of mercury, and heart rate is 110 breaths per minute. What is the most likely diagnosis? Pneumonia, asthma, COPD exacerbation, pneumothorax. How many feel pneumonia? What are the things that are against pneumonia in this question? Hyper resonance is against. Okay. Anything else? Pneumonia doesn't present with severe chest pain, right? In other than unusual cases. Asthma, Asthma, in asthma that they didn't mention anything about the wheeze, and also like you won't see usually the hyper resonance. Then COPD exacerbation, can they present like this? They can present with dyspnea, they can present with decreased resistance, but hyper resonance is unlikely and chest pain is unlikely. Then pneumothorax, this hyper resonance, this among this one word hyper resonance gives us the clue. Understood? So the patient's symptoms and physical examination findings are suggestive of a pneumothorax, which is characterized by presence of air in the pleural space. Pneumonia, this generally presents with fever, productive cough, and dyspnea, but not with unilateral decrease in breath sounds, and hyperresonance is seen in this patient, which is not seen. Then asthma, this typically presents with wheezing, chest tightness as discussed, shortness of breath, but not with unilateral decreased breath sounds. COPD exacerbation, this would typically present with increased SOB and sputum production, and color change will be there. Usually it might be yellowish to greenish, and not with the physical findings. This hyperresonance and all won't be seen. Pneumothorax, this is the most likely diagnosis given the patient's sudden onset of severe chest pain and dyspnea, decreased breath sounds, and hyperresonance on one side of the chest. Again, what is the difference between a simple pneumothorax and tension pneumothorax? One more line they will add in the question. Who told that? Who told that word trachea? Very good. Give him a big round of applause. In the question, by giving the clinical thing, they add one sentence that there is a deviation of trachea to the opposite side, then that indicates with the same thing, it decreases breath sounds and hyper resonance with deviation that indicates a tension pneumothorax. Okay, good. So pneumothorax patient often presents with sudden onset dyspnea and chest pain. Physical examination may reveal decreased breath sounds and hyper resonance on the affected side. Clear about this, guys? Fine, clear? Then coming to neurological emergencies. See here, in respiratory, pneumothorax is very important managing. Then acute exacerbations of asthma and COPD. Then coming to the embolism, pulmonary embolism management. These are the important things. Then coming to neurological emergencies. A 72-year-old man is brought to the emergency with acute onset of right-sided weakness and slurred speech that started an hour ago. His blood pressure is 170 by 95 millimeters of mercury. He has a history of hypertension and type 2 diabetes. His blood glucose is within normal limits. What is the most likely diagnosis and the appropriate next step in the management? Here there are two questions asked. They are also asking about the diagnosis and also the most appropriate initial options. Option 1, transient ischemic attack, managed to start anticoagulation. Acute ischemic stroke, administer TPA. Hypertensive encephalopathy, lowering the blood pressure. Diabetic neuropathy, optimize the glycemic control. How many for option 1? How many for option 2? Good. How many for option 3? How many for option 4? Okay. In this context, what are the clues in the question? Acute onset, right-sided weakness. Is there slurred speech? What is, do you know fast? What is fast? What is fast? Yes, calling emergencies. We'll discuss about the fast in a minute. That started an hour ago. Here, it started an hour ago, and this blood pressure is 170 by 95. History of hypertension is there, type 2 diabetes. His history of hypertension, diabetes, all these things produce this is the vascular risk factors for acute ischemic stroke. Yes or no? Come on, guys. So how do you manage this? Here, why can't it be transient ischemic attack? We'll discuss. Hypertensive encephalopathy, hypertension is there, but in this condition, if you rapidly decrease the blood pressure, what happens? If suppose this is the ischemic area and this is the ischemic penumbra, the blood supply to this area will be compromised if you rapidly decrease the blood pressure. Okay. Diabetic neuropathy, in this context, the glycemic control is good. The patient's acute onset of focal neurological deficits and the history of vascular risk factors are suggestive of an acute ischemic stroke. The time since the symptom onset. How much is the symptom onset time here? Just 1 hour is within the therapeutic window for intravenous thrombolysis with TPA. Okay, within that this is called as time to drug. When you say like door to needle time, when you see door to drug time and all with TPA, which is recommended within 4.5 hours from the symptom onset in eligible patients. So TEA, transient ischemic attack, usually are characterized by mainly focal neurological symptoms that usually completely resolves within 6 to 24 hours. Okay, and given the ongoing symptoms in this patient, acute ischemic stroke is more likely. And obviously, when during the in this window, you can't use anticoagulation. Then, as we discussed, acute ischemic stroke, the patient symptoms history like that weakness and droop, and also slurred speech and all, they all fall into this acute ischemic stroke. Within 4.5 hours of symptom onset is thrombolysis using TPA, provided there are no contraindications. Then hypertensive encephalopathy, as I said, the condition usually presents with headache. Usually hypertensive encephalopathy presents with headache, nausea, vomiting, and seizures. Headache, nausea, vomiting, seizures, and altered consciousness, which is not seen in this patient. Also remember, aggressive blood pressure lowering in acute ischemic stroke can decrease the perfusion to the ischemic penumbra, so that cause further worsening. So very, very, very important about this. Then diabetic neuropathy generally presents with chronic symptoms and do not cause focal deficits. Particularly in this case, blood glucose levels are normal. So acute ischemic stroke often presents with sudden onset of focal neurological deficits. Intravenous thrombolysis with TPA, tissue plasminogen activator, is the treatment of choice within 4.5 hours from symptom in eligible patients. Clear about this? How can differentiate? Then a 20-year-old is brought to the emergency department with generalized tonic-clonic seizures lasting for 2 minutes. She regains consciousness, but within a few minutes, she has another seizure. She has no history of seizures and no obvious precipitating factors. What is the most likely diagnosis and the initial management? Epilepsy, start anti-epileptic medication. Meningitis, start empiric antibiotics. Status epilepticus, administer IV benzodiazepines. Hypoglycemia, administer IV dextrose. How many feel option 1, epilepsy, start anti-epileptic medication? Lift your hands properly. Okay. Second, meningitis, start empiric antibiotics. 3, status epilepticus, administer IV benzodiazepines. 4, hypoglycemia, administer IV dextrose. So for those who opted for option 1, what made you think so? Or for those, see, obviously it can't be hypoglycemia, because here in the hypoglycemia can throw seizures. Yes or no? But here in the question, we didn't have any clue about the patient is having hypoglycemia. They didn't mention RBS level. So this is ruled out. So then come up between 3 options. Here meningitis, for meningitis, anything like fever, neck stiffness, and all these things are not mentioned. So meningitis is also ruled out, though it can throw seizures. Now the confusion between epilepsy and status epilepticus. So here, why do you feel it is a status epilepticus, or why can't it be, or why do you feel it is an epilepsy? Exactly. See here, another attack within a few minutes, and the patient completely can't regain the consciousness. She's still in that phase. Okay, that itself defines the status epilepticus. Okay, in status epilepticus, you have to administer immediately the drug. Usually the first line of treatment is benzodiazepines. All the patient can later on, you can start the complete anti-epileptic medications and all, you can take care. So the patient's presentation of 2 seizures without full recovery of consciousness, 2 seizures without full recovery of consciousness in between is consistent with status epilepticus, which is a neurological emergency. The initial management of status epilepticus involves securing the airway, because the patient can bite it and it might be fine. They might go into respiratory difficulty, stabilizing the vital signs, and administering a fast-acting anti-epileptic medication like benzodiazepine, lorazepam or diazepam or midazolam, whatever is available. So epilepsy is characterized by, see here, recurrent unprovoked seizures. However, the acute management of patient with ongoing seizures focus on stopping the seizures with a fast-acting anti-epileptic medication rather than the maintenance therapy. Obviously, you try giving the benzodiazepines like midazolam, lorazepam, or diazepam. Then meningitis, see, when meningitis, it can also cause seizures, but usually other symptoms like headache, fever, or neck stiffness will be there to suggest meningitis. Antibiotics would not be the appropriate in this condition. Antibiotics would not be the appropriate initial therapy because the patient has ongoing seizures and you don't have any history about meningitis. Then status epilepticus, the patient's presentation of 2 seizures without full recovery of consciousness is consistent with the status epilepticus. First line treatment, as discussed, IV benzodiazepines. Hypoglycemia. Hypoglycemia also can cause seizures, but here in the question, there is no clue about how this hypoglycemic seizures can present. Moreover, the primary treatment of ongoing seizures is stop seizures with anti-epileptic medication. So status epilepticus is a neurological emergency characterized by ongoing seizures of or 2 or more sequential seizures without full recovery in between. The first line treatment is IV benzodiazepines. Clear about this? The status epilepticus, yeah. Regains consciousness, but when you see this, it is not completely recovered. So that's what it is in the question also. You see that what is the most likely diagnosis and the initial management. And initial management, you won't go ahead with the anti-epileptic medications properly rather than giving the first line of treatment. That is why all these questions we use it to give for a trickiness so that you can pick up the clues in between and answer. In this 1 and 3, both can be the answers, but we are trying to pick up which is the most appropriate. Got it? There will be another 2 questions. Then she can go for obviously epilepsy, provided she is not in the status epilepticus. She is not throwing seizures continuously. And in that condition, she has to continue her anti-epileptic medications and then immediate. Okay. Her regular anti-epileptic medications has to be given, and securing the airway is the paramount. In these options, in any of these options, if securing the airway option is there, like in this condition, that will become a most appropriate. Got it? Then, yeah. More than 5 minutes. Yes. Yes. See, she's brought to emergency department with GTCS lasting for 2 minutes, only 2 minutes, and provided she regained consciousness, but within a few minutes, it again started. Within a few minutes, it again started. Here, it's not completely regained. Whether she has completely recovered, that is not been clearly mentioned in this question. Okay, in this question, though 1 and 3 are close, considering this, the immediate management, even if we think about epilepsy at this context, this won't go in favor of starting anti-epileptic medications at this, right? Like both the things should suffice. Suppose even if the question has been given, the options are given epilepsy with administer IV benzodiazepines, then it would have been a correct option. But here, epilepsy with starting anti-epileptic medications is going to be the controversial. Here, the focus is administering IV benzodiazepines. Diagnosis can be epilepsy or status epilepticus, depending on that. Here, the most appropriate will be the IV benzodiazepines. Okay, then a 45-year-old man presents to the emergency department with severe epigastric pain radiating to the back for past 6 hours. The pain is associated with nausea and vomiting. He has a history of alcoholism. His pulse is 110 blood pressure beats per minute. Blood pressure is 90/60. Lipase level is 3 times the upper limit of normal. What is the most likely diagnosis and the appropriate next step in the management? Acute pancreatitis with aggressive fluid resuscitation, gastritis, administer proton pump inhibitors, peptic ulcer disease, perform endoscopy, acute cholecystitis, perform ultrasound. How many for option 1? How many for 2? How many for 3? How many for 4? Okay, what are the clues here? epigastric pain radiating to the back, 6 hours, associated with nausea, vomiting, history of alcoholism, vitals, and importantly, lipase levels. These are the questions. In this, they're also asking about the diagnosis and management. Now tell me, what are the conditions which are favoring the pancreatitis, as you told? Almost everything, epigastric pain, which is radiating to the back, history of alcoholism, radiation to back, epigastric pain, alcoholism, lipase levels. So all these things go into acute in the treatment of acute pancreatitis, and treatment of acute pancreatitis, fluid resuscitation is very, very, very important. For the reason, if you won't correct, I mean, what is the importance of giving fluids in acute pancreatitis? You resuscitate, right? Like in pancreatitis, you resuscitate. What is the importance of this? What is the importance of fluids here? One is R2 digestion and enzymes, and another most important thing is usually what happens as the time progresses. If you won't resuscitate properly, the lactate keeps accumulating, and the patient may go into systemic inflammatory response syndrome to prevent this. Okay. Then gastritis. See, gastritis, what are the factors which are favoring and what are the factors that are against? What are the factors that are favoring? Epigastric pain. It can be with nausea, vomiting. What are the factors that are against? One, radiating to the back, and lipase levels. Then peptic ulcer disease. What are the things that are favoring? Nausea, vomiting, alcohol plus minus. Okay, but lipase levels, that doesn't fit into this. Acute cholecystitis. What are the things which is contradicting? One, usually where does the pain of acute cholecystitis come? Right hypochondrium. Okay, so the patient's presentation of epigastric pain radiating to the back, history of alcoholism, and elevated lipase are suggestive of pancreatitis. The first line of management in acute pancreatitis is aggressive fluid resuscitation to prevent or treat hypovolemia, which can lead to systemic inflammatory response syndrome and organ failure. So this is very, very, very important. Okay, and acute pancreatitis, the aggressive fluid is the patient's symptoms, history, lipase levels point to acute pancreatitis. The initial treatment is aggressive fluid resuscitation to maintain perfusion and prevent complications. Gastritis, as we discussed, while gastritis can present with gastric pain, it does not cause elevated lipase levels. Gastritis also does not typically cause severe pain radiating to the back. Peptic ulcer usually can cause severe epigastric pain, but typically doesn't cause elevated lipase levels, or systemic symptoms like hypotension and tachycardia. Then coming to acute cholecystitis, performing ultrasound and right upper quadrant pain, as we discussed, and it does not cause elevated lipase levels. Then coming to our next question. Yeah, acute pancreatitis often presents with severe epigastric pain radiating to the back and is associated with nausea and vomiting. The initial management of acute pancreatitis involves aggressive fluid resuscitation. A 65-year-old man with a history of diabetes and COPD presents to ER with high-grade fever, chills, cough with purulent expectoration, and dyspnea for the past 2 days. His vitals show temperature of 39.5 degrees centigrade, pulse rate of 110 per breaths per minute, respiratory rate of 30 per minute, and blood pressure of 90 by 60 millimeters of mercury. Physical examination reveals decreased breath sounds and queers crackles in the right lower lung field. Chest X-ray reveals consolidation in the right lower lobe. What is the most appropriate next step? Start inhaled bronchodilators, initiate broad spectrum antibiotics and fluids, administer supplemental oxygen, and monitor the patient. Schedule for bronchoscopy. So first of all, come to the diagnosis. What do you think is the diagnosis here? So what are the things in the question here? Diabetes, history of diabetes is there. COPD is there. Now he has high grade fever, chills, cough with purulent expectoration. Dyspnea is there since 2 days. Patient is having a temperature 39.5. Tachycardia is there. Tachypnea is there. Hypotension is also there. Physical examination, you see the decreased breath sounds and coarse crackles. Chest X-ray shows consolidation. So what is it fitting into? Is it acute exacerbation of COPD? So what do you, in this condition, how many feel that start inhaled bronchodilators? Second, initiate broad spectrum antibiotics and fluids. Administer supplemental oxygen and monitor. Schedule for bronchoscopy. The most appropriate answer is initiate broad spectrum antibiotics and fluids. Here, as said, like symptoms of fever, chills, purulent expectoration, dyspnea, along with physical examination, radiographic graphics, suggest community acquired pneumonia. Here, the presence of hypotension indicates the presence of hypotension in this patient, and also tachypnea that indicates severe community acquired pneumonia. In the severe community acquired pneumonia, there are initial empiric broad spectrum antibiotics covering usually the most common the pathogens like strep pneumonias and legionella pneumonia, along with fluid resuscitation to treat this hypotension component. So inhaled bronchodilators are typically used in patients with obstructive lung diseases like asthma and COPD. However, this patient's presentation is more consistent with the bacterial pneumonia. Then, as we discussed, the patient with having fever, purulent expectoration, lobar consolidation on chest X-ray, all these things have severe, this indicates severe community acquired pneumonia. And for this, antibiotic treatment and fluid resuscitation for hypotension is important. Then coming to administer supplemental oxygen and monitor. So supplemental oxygen here in this particular context, as discussed, in acute supplemental oxygen is the most important thing in which conditions? Acute exacerbation of COPD, provided the patient, if the same patient has respiratory acidosis, then go for non-invasive ventilation. Then schedule for bronchoscopy. Bronchoscopy is not typically required in the initial management of community acquired pneumonia. Then severe community acquired pneumonia often presents with fever, cough with purulent sputum, dyspnea, and may be associated with hypotension. The initial management of severe community acquired pneumonia indicates immediate initiation of empiric broad spectrum antibiotics and fluid resuscitation. And then a 30-year-old woman presents to the emergency department with high-grade fever, severe headache, neck stiffness, and photophobia for the last 2 days. Physical examination reveals a positive Kernig sign and Brudkin's sign. Lumbar puncture reveals elevated opening pressure, elevated protein, decreased glucose, and increase in neutrophils. What is the most likely diagnosis and immediate next step in the management? Subarachnoid hemorrhage, and you schedule the patient for a CT scan. Encephalitis, start acyclovir. Bacterial meningitis, initiate broad spectrum antibiotics and dexamethasone. Tension headache, administer analgesics. What is the answer? First, what is the diagnosis? Bacterial meningitis. What are the things that are favoring that? High-grade fever, severe headache, neck stiffness is there, photophobia, positive Kernig and Brudkin sign, lumbar puncture also, you see, elevated protein, decreased glucose, and increased neutrophils. So what are the things? So this is correct. Initial broad spectrum antibiotics and dexamethasone to reduce the inflammation, you do this. Then what are the things that are against the tension headache? Even this, what are the things that are favoring or which are against the tension headache in this condition? So this Kernig sign, Brudkinski sign, this elevated protein, decreased glucose, all these things are against the tension headache. Then encephalitis. Encephalitis, if you do lumbar puncture also there, you see morely lymphocytosis rather than here you see more of lymphocytosis. And there also you won't see this predominantly this neck stiffness features. Then subarachnoid hemorrhage. Subarachnoid hemorrhage can present with the headache, but this elevated protein, decreased glucose, all these things are irrelevant. The patient's symptoms of fever, severe headache, neck stiffness, and photophobia, along with physical findings and CSF analysis, are highly suggestive of bacterial meningitis. The initial management of suspected bacterial meningitis is immediate initiation of empiric broad spectrum antibiotics along with dexamethasone to reduce the risk of neurological complications. While subarachnoid hemorrhage can often present with headache, the presence of fever, neck stiffness, and signs of meningeal irritation suggest an infectious cause. CSF analysis also doesn't fit into this category. Then encephalitis, as discussed, it can present with fever, headache, and it can present with altered mental status. Encephalitis can present with altered mental status, but typically it doesn't cause this neck irritation, meningeal irritation, and neck stiffness. Also, CSF, it has lymphocytic predominance rather than the neutrophilic, which is important. Then bacterial meningitis, initiate broad spectrum antibiotics and dexamethasone. The patient's symptoms, physical examination findings, all the CSF analysis, they points to this. Tension headache, it doesn't cause fever, neck stiffness, or changes in the CSF. Okay. Then coming to the next question. Oh, sorry. Bacterial meningitis often presents with fever, severe headache, neck stiffness, and signs of meningeal irritation. The initial management of bacterial meningitis includes immediate initiation of empiric broad spectrum antibiotics and dexamethasone. Then coming to endocrine emergencies. A 45-year-old woman with a history of type 2 diabetes mellitus presents to the ER with severe pain abdomen, vomiting, and polyuria for the past 1 day. Her blood glucose is 500 mg per deciliter. Serum osmolality is 350 milliosmoles per kg. Urine ketones are negative, and ABG shows a pH of 7.3 with a bicarbonate of 18 milliequivalents per liter. What is the most appropriate next step in the management? So first of all, come to what is the diagnosis? What is the diagnosis? What is the diagnosis? Yeah. What is the diagnosis in this question? First, like, is it DKA or non-ketotic, hyperosmolar coma? It is hyperosmolar coma because in this question, if you see this, the clues type 2 diabetes mellitus presents to your severe abdominal pain. Usually what happens is when we see severe pain abdomen, we usually tend to go for DKA. But see here, vomiting and polyuria is there, and blood glucose is 150 and serum osmolality is 350. Serum osmolality is high in this condition, and serum osmolality is high. Ketones are negative, and ABG pH is 7.3 only, bicarb 18 milliequivalents per liter. Okay, usually, and what is the most appropriate? Initiate IV fluids, insulin, and potassium. Start oral hypoglycemic agents. Administer bicarbonate infusion. Initiate antibiotics. How many feel initiate antibiotics? So there's no, in this context, there's no infection to start there. Administer bicarbonate infusion. Even though the bicarb is only 18 instead of 24, the pH is still 7.3. Usually, though theoretically they say 6.9, but only if pH goes below 7.1 to 7.15, you start correcting the bicarb. Then oral hypoglycemic agents. Can you use oral hypoglycemic agents in this context? So you give IV. So treat patient IV fluids, giving the insulin and potassium correction is very, very, very important. Okay. So the patient's symptoms with hyperglycemia, hyperosmolality, and metabolic acidosis, along with negative urine ketones, are indicative of hyperosmolar hyperglycemic state. This condition is a serious complication of diabetes and characterized by severe hyperglycemia and hyperosmolarity with significant ketosis. The cornerstone is aggressive rehydration with intravenous fluids, correction of hyperglycemia with insulin, and correction of electrolyte abnormalities, especially potassium. In HHS, the first line treatment includes aggressive rehydration to correct the severe hydration. What happens if you won't do this? Usually because of this osmosis, diuresis occurs. This diuresis occurs, you have to correct that. If you won't correct this osmotic diuresis, the patient will become more dehydrated and lactate will be accumulated in the body and further electrolytes will be depleted. Oral hypoglycemic agents. Oral hypoglycemic agents are inadequate and can in fact exacerbate the dehydration. Bicarbonate infusion, as I said, like those, it's not theoretically 6.9, at least like the pH should be less than 7.1 and 7.2 to do that. Then initiating antibiotics are not indicated unless there's an underlying infection. So the differences between DK and HHS might have been covered in your medicine, and I'm not going into depth in this. HHS is a complication of diabetes characterized by severe hyperglycemia, hyperosmolality, and mild metabolic acidosis with significant ketosis. Without significant ketosis. If ketosis is there or ketoacidosis is there, it will become diabetic ketoacidosis. There also the main cornerstone of treatment is IV fluids administering and also correcting the insulin potassium. Here, aggressive dehydration with IV fluids, correction of hyperglycemia with insulin, and correction of electrolyte abnormalities. Then coming to another endocrine. A 35-year-old woman with history of Graves' disease presents to the emergency department with palpitations, tremors, and a temperature of 39.8 degrees centigrade. On physical examination, she appears restless and anxious, has a pulse rate of 140 beats per minute, and exophthalmos. What is the most likely diagnosis and the appropriate next step in the management? Panic disorder, start cognitive behavioral therapy, pheochromocytoma, schedule for CT scan, thyroid storm, initiate beta blockers, anti-thyroid drugs and steroids, meningitis, perform lumbar puncture. How many for option 1? How many for option 2? Option 3? 4? So what are the clues in the question which are favoring option 3? Very good. Graves' disease, palpitations, tremors, increase in temperature, exophthalmos. So all these are giving clues of thyroid toxicus and thyroid storm. Okay. So this thyroid storm and all, you have to treat with initiate beta blockers, anti-thyroid drugs and steroids. So this tachycardia and occasionally the palpitations, all these things can also occur in pheochromocytoma. Pheochromocytoma, what happens? It releases adrenaline, noradrenaline. It may also cause sympathetic stimulation, causing tachycardia and all. But why can't it be the answer here at pheochromocytoma in this question? The question has another clue of Graves and exophthalmos is there, so it can't be that. Okay. Then why can't it be a panic disorder? Temperature, fever, though the panic disorder may cause this anxiety and restless and pulse increase, tachycardia can also be there, but this clinical features might be absent. Then meningitis, why can't it be meningitis? No meningeal signs like are in the conditions of what do you say, like neck stiffness and all are absent. So the patient's symptoms of palpitations, tremors, high-grade fevers, and signs of hyperthyroidism are indicative of thyroid storm, a severe and potentially life-threatening complication of hyperthyroidism. The recommended management is prompt initiation of beta blockers to control the adrenergic symptoms, anti-thyroid drugs to decrease the thyroid hormone synthesis, steroids to decrease the peripheral conversion of T4 to T3. All these are important. One, the adrenergic symptoms, what are there? To control that, you need beta blockers. And anti-thyroid drugs are required to decrease the thyroid hormones synthesis and steroids to decrease the conversion of T4 to T3. So panic disorder, as discussed, patient restless anxiety palpitations can be seen in the panic disorder, but not the high-grade fever, exophthalmos and all. Pheochromocytoma, they cause palpitations and tumors, but it does not typically cause a fever, or additionally, because the history of Graves' disease is there. Then meningitis can cause fever and restlessness, but palpitations, tremors, exophthalmos can't be explained with this. So thyroid storm, as we know, is a potentially severe and life-threatening complication of hyperthyroidism. The management of thyroid storm involves beta blockers. Why do you use beta blockers? To contradict adrenergic symptoms. Anti-thyroid drugs. Anti-thyroid drugs to decrease the thyroid synthesis, and steroids from T4 to T3 peripheral conversion. Okay, got it. Then coming to next question. A 25-year-old man is brought to the emergency department following a road traffic accident. He was a driver of a car and was wearing a seat belt. On examination, he's conscious, alert, but complains of severe pain abdomen. His pulse is 110 beats per minute. Blood pressure is 90/60. Respiratory rate is 22 breaths per minute. There's a contusion mark in the abdomen following the seat belt line. What is the most appropriate next step in the management? Urgent exploratory laparotomy, focused assessment with sonography for trauma, fast examination, arrange for psychiatric evaluation, immediate discharge with analgesics. So how many for urgent exploratory laparotomy? Okay. How many for fast? Okay. Arrange for psychiatric evaluation. Immediate discharge with analgesics. If you see next 4 to 5 questions, you are theoretically, I mean, though you are answering 4 questions, 4 options, it's only 3 options. Mainly, like whenever I kept like psychiatric evaluation, except in the psychiatric, it is not relevant here. In this, eventually, this patient might be needing or may need exploratory laparotomy, but here the patient is still conscious and alert. The patient is still conscious and alert. Severe pain abdomen is there. He is in a mild shock in the sense like 110 blood tachycardia and the blood pressure is 90/60. Respiratory rate is 22, is just fine. Contusion mark in the abdomen that indicates there is some internal injury is there. Still the patient is clinically relatively stable. So before going for urgent exploratory laparotomy, you can have time to see like what happens in fast. In fast, you see what happens. Is there any peritoneal fluid or like any accumulation is there? You will see that. So the patient's mechanism of injury, symptoms, and vital signs suggest the possibility of blunt abdominal trauma commonly seen in motor vehicle collisions. The abdominal contusion following the seat belt line further raises suspicion for this internal injury. So a rapid assessment of patient is necessary to identify potentially life-threatening injuries. Fast examination is quick and non-invasive method to identify free fluid, which is suggestive of internal bleeding, mainly at peritoneal regions, pericardial regions, and pleural spaces. That is what you do. So urgent exploratory laparotomy, while as we discussed, it may be necessary, but it would be premature to proceed a surgery without first attempting to identify where exactly is the bleed. Then fast, as we discussed, psychiatric evaluation is irrelevant. So though it might be needed, like the patient had a accident, the psychiatric support might be needed, but it's not in the acute conditions. Then immediate discharge with analgesics. After knowing this patients do with vital signs slightly unstable and mechanism of injury, immediate discharge will be inappropriate in this condition. So fast, we have to remember, very important. Blunt abdominal trauma can cause serious internal injuries and hemorrhage, which may not be immediately apparent in the clinic physical examination. Fast examination is a rapid and non-invasive method to identify free fluid suggestive of internal bleeding in trauma patients. Clear? Then a 30-year-old man presents to the emergency department with severe back pain after falling from a height. He is alert, oriented, cooperative. On physical examination, he has tenderness over the mid-thoracic spine with no obvious deformity. Neurological examination shows normal strength and sensation in all the limbs. What is the most appropriate next step in the management? Discharge home with analgesics, start IV antibiotics, obtain thoracic spine X-ray, immediate surgical referral for thoracic laminectomy. How many for option 1? Discharge home with analgesics. 2, start intravenous antibiotics. 3, obtain thoracic spine X-ray. 4, immediate surgical referral for thoracic laminectomy. See here, he presents with severe back pain after falling from a height. He's alert, oriented, and cooperative. Physical examination, he has tenderness, but there is no obvious physical deformity is not there. Neurological examination you have done, normal strength and sensation in all the limbs. So in this condition, what do? Obviously, discharging home with analgesics you can't do for the same reason, because there is involvement of spine and the patient has tenderness, so you have to evaluate. And IV antibiotics, the patient doesn't have any fever or anything which has open injuries here. And immediate surgical referral for thoracic laminectomy. If there's no obvious deformity, they are mentioning about no obvious deformity, in those conditions directly referring for thoracic laminectomy is foolish. So among this, the most appropriate is thoracic spine X-ray. So here, the potential thoracic spine injury, the initial evaluation should include as a physical and neurological examination, which has already been done. Is there any concerns for spinal injury? Imaging of the spine should be done. Plain radiographs can be the first line of modality. And if you feel that there is some imaging disturbance, you can also ask for CT and further MRI. And if initial X-rays doesn't give a clear picture. So as said, given the history of fall and presence of back pain, there is a risk of spinal injury. Discharging the patient without further evaluation would be inappropriate. Start IV antibiotics. There is no evidence of infection in this case. Antibiotics would not be indicated. Obtain thoracic spine X-ray. And X-ray is a quick non-invasive method, as we discussed. We can do, if you don't get a clarity, you can go for CT or MRI. And immediate surgical referral, although surgery may eventually be necessary depending on that, but at this particular point of time, it is too early to comment on this. A history of fall from a height with subsequent back pain raises concerns for potential spinal injury. Initial evaluation should include imaging, typically starting with plain radiographs to assess for potential fractures or other abnormalities. Then coming to the next question. A 35-year-old woman is brought to ER after a car accident. On examination, she is agitated. Heart rate is 120 beats per minute. Blood pressure is 85 by 55 millimeters of mercury, and respiratory rate of 28 breaths per minute. Her left arm is swollen and deformed. What is the most appropriate next step in the management? Discharge home with analgesics, arrange for psychiatric evaluation, immobilize the arm and assess the neurovascular status, immediate surgical referral for open reduction and internal fixation. How many for option 1? How many for option 2? How many for option 3? How many for option 4? So why can't it be option 4? Always, whenever possible, immobilization is the most important thing. Here, what are you suspecting here? A fracture. So immobilization is important, and whether it needs close reduction or open reduction, that can be taken care depending on the clinical examination and the investigations. So the patient's history of trauma, physical findings of an arm deformity and swelling suggest a potential fracture. Immediate step in managing extremity fracture involves immobilizing the injured limb to prevent further injury following an assessment of neurovascular status. The neurovascular assessment should include evaluation of what are the, you have to examine the peripheral pulses if they are present or not, and how is the capillary refill, skin color, temperature, and the function of nerves distal to the injury, how it is. And these steps are crucial in identifying any potential limb threatening. We have to always, whether it's a limb, when it comes to limbs, whether limb saving is the pivotal. So try as much as possible to check for, in this condition, if there is, in the question, if they ask about, if they add one more point about the distal pulsations are not there, then we have to, the answer slightly varies. So discharge home with analgesics. This absolutely is wrong. Arrange for psychiatric evaluation, wrong. Here, the presence of arm deformity and swelling in the setting of trauma suggests a potential fracture. The immediate step is to immobilize the limb and assess the neurovascular status. Here, immediate surgical referral for open reduction and internal fixation. So though the surgery may eventually be required, it is important first to stabilize the patient, immobilize the fracture, and assess neurovascular status. In this condition, in the question, if they ask about there's a loss of distal pulses or the patient is having a open cut injury, then you have to immediately go for surgery. Understood? So by changing a question, by slightly tweaking the question, how it varies. Understood, everyone? Yes or no? Then management of fractures begins with immobilization to prevent further injury, followed by thorough neurovascular assessment. Failure to identify and manage life-threatening complications, mainly compartment syndrome, vascular injury, can result in permanent disability or limb loss. So this neurovascular assessment, when I say neurovascular assessment, like checking the distal pulses, capillary refill, the color, as all discussed, these are very important. Evaluation of peripheral pulses, evaluation of peripheral pulses, capillary refill, skin color, temperature, function of nerves distal to injury. These are all very important. Then A 17-year-old girl is brought to the emergency department by her parents due to sudden onset of difficulty breathing. The parents report that the child was playing with her toys when she suddenly started coughing and have trouble in breathing. The child appears anxious and is drooling. She has a heart rate of 120 beats per minute. Respiratory rate is 40 per minute. Oxygen saturation of 95% on the room air. On examination, you note inspiratory stridor. What is the next most appropriate step in the management? Prescribe antibiotics for suspected bacterial pneumonia. Prepare for potential foreign body removal. Arrange for psychiatric evaluation. Immediate surgical referral for tracheostomy. How many for option 1? 2, 3, 4. Okay. See, in this condition, this is how the typical presentation, a child might be playing and suddenly there might be a difficulty in breathing. And if they give another clue here, what is another clue here? Child appears anxious and drooling. There's a drooling here and inspiratory stridor. This drooling, inspiratory stridor, playing with the toys, sudden onset of difficulty breathing. This all gives a clue of foreign body. So potential foreign body removal has to be done. See, what are the things that goes against bacterial pneumonia? In this, though the tachypnea can be there in pneumonia and difficulty in breathing, but it can't be so sudden. And the inspiratory stridor, you can't see this in here. Inspiratory stridor is against this. Inspiratory stridor and drooling, all these things are against the pneumonic picture. Then immediate surgical referral for tracheostomy. If you are not able to maintain the airway and because potentially you are not able to retrieve, then you might go for that. But initially you have to try for potential foreign body removal. So with the inspiratory distress with cough while playing, along with physical examination findings of drooling and inspiratory stridor, is concerning for a foreign body aspiration. This is a typical way how they describe the question about the foreign body aspiration. This is a common emergency, particularly under those children with less than 3 years. And so how do you do, how can you remove this? What is the maneuver? Heimlich's maneuver. And in addition, like how can you remove under anesthesia? Bronchoscopy, either rigid or like flexible fiber optic, you do this. Okay. Usually majority of the times for kids, like even the flexible fiber optic bronchoscopy may help about this. Then, although pneumonia can cause cough and difficulty breathing, the sudden onset when the child was playing suggests a foreign body aspiration. Then prepare for potential foreign body removal. The child's history and physical examination findings suggest a foreign body aspiration. Preparing for a potential removal either by bronchoscopy or emergency maneuvers is the most appropriate next. Psychiatry, that is immediate surgical referral, although it might be necessary, is a last resort. First step is always to attempting to remove the foreign body. Clear about this? Foreign body aspiration is a common emergency in young children and typically presents with sudden onset of coughing, choking, and difficulty in breathing. The management involves preparing for the potential removal of that foreign body, while see here, bronchoscopy being the preferred method in stable patients. Most of the times we do that. And one second. Okay. Coming to the next question. A 6-month-old boy is brought to the emergency department by his parents due to a fever and poor feeding. The parents also report the child appears more sleepy than usual. On examination, the child appears ill, is lethargic, and temperature of 38.5 degrees centigrade, that is 101.3 degrees Fahrenheit. There's no obvious source of infection on physical examination. What is the most appropriate next step in the management? Discharge home with antipyretics, perform a lumbar puncture to evaluate for meningitis, start antipsychotic medications, immediate surgical referral for appendectomy. How many for option 1? Discharge home with antibiotics. Why do you think discharge home with antibiotics is the right one? Why do you think so? No obvious source of infection. If there's no obvious source of infection, will we leave it like that? Sorry, in meningitis? In a kid, if you are not able to, in a kid, if there is no obvious source of infection, what should you suspect for? Meningitis you have to rule out, right? When the patient is running, particularly in kids, when they are running high temperatures, when there is no obvious source of infection, you should rule out meningitis. In a child of this age who is presenting with fever, lethargy, poor feeding, and serious bacterial infection, meningitis should be considered, especially when there are no obvious source of infection. This is very, very, very important. The question similar to this was asked in INSET 2021. Almost similar question. Okay, a lumbar puncture is necessary to evaluate a meningitis for in these children. Other investigations, like you can do all these things like blood counts, urine analysis and all, but most commonly considering this, you can't leave the patient without evaluating the meningitis component by doing the lumbar puncture. So given the age of this child and clinical presentation, serious bacterial infections such as meningitis must be considered. Discharging without further evaluation with just the antipyretics would be completely inappropriate. And in a febrile lethargic infant, febrile is there, lethargic is there with no obvious source of infection, meningitis must be considered. A lumbar puncture is necessary to evaluate this for this condition. Then antipsychotic is irrelevant. So appendicitis can cause fever. This is extremely rare in this infant. So here you are answering between two options only, you have to rule out. Then in febrile infants, this is very, very important, especially those who are lethargic and are not feeding well, meningitis should be considered. Evaluation of this should include a lumbar puncture to assess for meningitis. Clear about this? Then a 28-year-old woman, 6 weeks postpartum, presents to the emergency department with severe lower abdominal pain, fever, foul-smelling vaginal discharge for the past 2 days. She delivered vaginally and had an uncomplicated postpartum period with onset of this until the onset of these symptoms. On physical examination, the patient is febrile, tachycardic, and her lower abdomen is tender on palpation. Pelvic examination reveals a tender uterus. Her laboratory results show a raised white cell count. What is the most likely diagnosis? Postpartum endometritis, ectopic pregnancy, pelvic inflammatory disease, ovarian cyst rupture. How many for postpartum endometritis? How many for ectopic pregnancy? How many for PID, pelvic inflammatory disease? How many for ovarian cyst rupture? What are the conditions? What are the things that are favoring postpartum endometritis, or what are the things that are favoring pelvic inflammatory disease, or what are the things which are against that? Here in this clue, one is 6 weeks postpartum, presents to the endometrium with severe lower abdominal pain, fever, foul-smelling vaginal discharge for the past 2 days. She delivered vaginally and has an, remember, uncomplicated postpartum period until the onset of these symptoms. On physical examination, she is febrile, tachycardic, her lower abdomen is tender on palpation. Pelvic examination reveals a tender uterus. Lab shows raised white cell count. This is obvious. What is the most likely diagnosis? See here, how does PID presents, pelvic inflammatory disease presents? It also has lower abdominal pain. It usually will be chronic. And also remember, one most important thing is postpartum endometritis can be onset from 1 week to 6 weeks. It can be with any onset, like even might be with cesarean section or with the vaginal delivery. The patient's presentation of fever, abdominal pain, and foul-smelling lochia in the postpartum period is suggestive of postpartum endometritis. This is an infection of the decidua that typically presents within the first week postpartum, but can occur any time up to 6 weeks postpartum. Risk factors, it can be with cesarean, prolonged labor, prolonged rupture of membranes, and chorioamnionitis. Treatment involves broad spectrum antibiotics. Here, all these things fits into this. Pelvic inflammatory disease, although this condition can present with lower abdomen, it is less likely given the patient's recent delivery and the presence of foul-smelling lochia. That is why the answer is postpartum endometritis. Clear about this? Yes or no? Then Ovarian cyst rupture, it can also cause acute pain abdomen, but usually it doesn't cause any foul smelling vaginal discharge or fever typically. And ectopic pregnancy, if it is ectopic pregnancy, usually ectopic pregnancy presents with unilateral pain and vaginal bleeding will be there, and positive pregnancy test. These are the things: positive pregnancy test, vaginal bleeding, unilateral pain will be described. Okay, here in this particular condition, the clinical scenario is mostly manifesting towards the infection rather than the ectopic pregnancy. Clear? Then, so as postpartum endometritis is an infection of the decidua, that is endometrium, after delivery. It presents typically within the first week postpartum, but can occur up to 6 weeks postpartum. Symptoms include lower abdomen pain, fever, and foul smelling lochia. Treatment involves broad spectrum antibiotics. Then, a 32-year-old woman, gravida 2, para 2, presents to the emergency department with severe right lower quadrant pain that started suddenly an hour ago. She denies any vaginal bleeding. She is hemodynamically unstable. On physical examination, she has lower right quadrant tenderness with rebound. Her UPT is negative. Ultrasound reveals a mass in the right adnexa with internal echoes and free fluid in the pelvis. What is the most likely diagnosis? Appendicitis. How many for appendicitis? Ovarian cyst rupture? Ectopic pregnancy? Pelvic inflammatory disease? What about other people? What about other people? How many for appendicitis? Lift your hands. Why do you think it is appendicitis? What are the things that are supporting and what are the things that are against? You only tell. Rebound tenderness, okay. Anything else? What, right adnexa, right upper, right lower quadrant pain. What are the things that goes against that? Okay, pain. Then coming to appendicitis, ovarian cyst rupture. What are the things that is favoring? Pain is there. Sudden onset. And UPT negative. UPT negative goes against the ectopic pregnancy, and ultrasound reveals mass in right adnexa and usually unilateral. If you see this, right lower quadrant pain, tenderness with rebound, ultrasound showing a mass in right adnexa with internal echoes, which suggest free fluid in pelvic area, suggest an ovarian cyst rupture. Here, this condition occurs when a cyst in the ova ruptures, leading to intra-abdominal bleeding. Patients typically presents with onset of sudden, severe, sharp lower quadrant pain. In appendicitis, although the lower appendicitis can present with lower quadrant pain, the presence of mass in the adnexa and free fluid in ultrasound is more suggestive of ovarian cyst rupture, which may cause the bleeding. This is important. Then ovarian cyst rupture, the patient's symptoms of, as we discussed, acute right lower quadrant pain, findings of mass in the adnexa and free fluid in pelvis are suggestive of ovarian cyst rupture. Then ectopic pregnancy could also be present with similar symptoms, but here negative urine pregnancy test. Ectopic pregnancy also can present with unilateral pain, but also there's no vaginal bleeding also in this condition. So the two things which goes against here is against are negative UPT and vaginal bleeding is absent. Then PID can cause lower quadrant pain, typically presents with bilateral lower abdominal pain, fever, and abnormal vaginal discharge. Ultrasound findings are also suggest of ovarian cyst rupture in this condition. So the ovarian cyst rupture usually presents with sudden onset of severe, sharp lower quadrant pain. Ultrasound can confirm the diagnosis by revealing a mass in adnexa with internal echoes. This is very important here. Management, usually when ovarian cyst rupture, you control the pain. Pain control will be there. And if hemodynamic instability is there, go for surgical intervention. Okay, this is about ovarian cyst rupture. Then A 24-year-old woman is brought to the emergency department by her family for her erratic behavior over the last week. They describe her as being unusually energetic, not sleeping, talking excessively, and making unrealistic plans to start a new business. She also has maxed out her credit cards with impulsive purchases. She has no past medical history or prior psychiatric history. On examination, she is extremely talkative and is easily distracted during the interview. What is the most likely diagnosis? Bipolar disorder, manic episode, bipolar disorder with manic episode, schizophrenia, ADHD, attention deficit hyperactivity disorder, OCD. How many for option 1? How many for option 2? How many for option 3? How many for option 4? For those who lift their hand for 3, here she might be attention seeking, but here, if you see this question very characteristically, unusually energetic, talking excessively, that grandeur, making unrealistic plans to start a new business, and maxing out the credit cards, impulsive. This is called the manic episode in a bipolar disorder, basically. Okay. The patient's symptoms of increased energy, decreased need for sleep, talkativeness, distractibility, impulsive behavior, spending sprees, unrealistic business plans, all this typically in less than a week's time, manic episode, which is a defining feature of bipolar disorders. Other features of manic disorders: inflated self-esteem, grandiosity, increased involvement of activities that has potential or painful consequences. As we discussed about bipolar. Schizophrenia is usually characterized by, in the clinical question, they give about hallucinations, delusions, disorganized speech or behavior. It might be negative symptoms like affective flattening, alogia, anhedonia. What is anhedonia? What is anhedonia? Lack of pleasure and motivation, evolution. Although there can overlap in symptoms between schizophrenia and bipolar disorder, here it is more consistent with the manic episode. ADHD, although ADHD has symptoms of inattention, hyperactivity, and impulsivity, it is a chronic disorder, usually starts from the childhood and it progresses. Okay. And OCD is characterized by obsessions like intrusive thoughts and compulsions, repetitive behaviors, which is not described in this patient in this clinical scenario. So manic episodes are characterized by a period of abnormally elevated, expansive, or irritable mood and persistently increased goal-directed activity or energy. And during the period of mood disturbance, 3 or more of the following symptoms will usually be present. Inflated self-esteem or grandiosity will be there. Decrease in need for the sleep, which is given in the question. Being more talkative than usual, this is also given in the question. Flight of ideas or subjective of thoughts that are racing. Distractibility. And if you see this word distractibility in the question, they have been given. She is being easily distracted during the interview. Can you notice this? She is extremely talkative and easily distracted during the interview. 1, 2, talking excessively, not sleeping. Okay. Then a 22-year-old boy is brought to the emergency department by his parents because of his increasing social withdrawal and poor academic performance in over the last 6 months. They also noticed that he has been laughing to himself and muttering, and he told them that he can hear voices talking about him. He denies any drug use and has no past medical or psychiatric history. Physical examination and laboratory tests are unremarkable, are normal. What is the most likely diagnosis? Major depressive disorder, schizophrenia, bipolar disorder, borderline personality. How many for major depressive disorder? How many for schizophrenia? How many for bipolar disorder? How many for borderline personality disorder? Okay. What it made you think about major depressive disorder or like bipolar disorder? Social withdrawal. Okay. Social withdrawal in the depressive episodes, it explains. Poor academic performance, it also can be explained. Then what is about like laughing to himself, muttering, hearing the voices? So what about laughing to himself, muttering, hearing the voices, hallucinations, delusions? Where do that fit in? Schizophrenic. And also this in schizophrenic, as discussed in the last question, the previous question, the patient will be also having anhedonic features, evolution, then negative features like affective flattening will be there. All this can also be seen in schizophrenia. So the patient's symptoms of social withdrawal, academic deterioration, inappropriate laughter, and auditory hallucinations, that is hearing voices talking after him, that have persisted for 6 months are suggestive of schizophrenia. This is one more thing which goes against the depressive episodes, like where time gap. You see the manic and depressive episodes, they keep waxing and waning. The onset is typically late adolescence or early childhood, and symptoms must persist for at least 6 months. See, major depressive disorder is characterized by a period of at least 2 weeks during which there is either depressed mood or the loss of interest or pleasure in any regular activities, and the patient's symptoms of auditory hallucinations and social withdrawal lasting for 6 months. So two things which goes against here is 6 months and also this auditory hallucinations. As I said, schizophrenia, social withdrawal, academic deterioration, inappropriate laughter, auditory hallucinations, all these things will fall into this schizophrenic category. Then bipolar disorder, characterized by episodes of mania and periods of depression. This patient doesn't have any symptoms of mania or depressive episodes, the diagnosis is unlikely. Then borderline personality disorder, characterized by the instability in interpersonal relations. There are like various personality disorders like A, B, C types, like anxiety, histrionic types, borderline personality, and all that itself is a different question. And this person, he won't fit into this social withdrawal in borderline personality disorders. So schizophrenia is characterized by hallucinations, delusions, disorganized speech or behavior, and as mentioned, negative symptoms like affective flattening, alogia, and evolution. The onset is typically late in adolescence or early adulthood, and symptoms must persist for at least 6 months. So early signs of this is very important. Early signs of schizophrenia include social withdrawal, unusual behaviors, and a drop in the academic performance. Clear about this? So with just these features, we can't attribute to the major depressive disorders. Then next question. A 22-year-old woman is brought to emergency department with nausea, vomiting, and abdominal pain. She also has double vision and drooping of both eyelids. On examination, her vital signs are normal. She has bilateral ptosis and her pupils are dilated and poorly responsive to light. What is the most likely cause of this patient's symptoms? How many for alcohol intoxication? Opioid overdose, botulism, cocaine intoxication. Okay. So what made you, majority of you think about botulism? Why can't it be opioid? With one word, you can eliminate opioid overdose. Pinpoint pupils. See here, it is the dilated pupils. Okay. Then cocaine. Fantastic. Give him a big round of applause. Cocaine causes usually like a rapid dopamine surge, and it causes sympathetic stimulation causing tachycardia. Here, if you see this, vital signs are normal. By this, you can directly eliminate this. Then coming to alcohol intoxication, usually this drooping of eyelids and with pupils are dilated, which are purely responsive, bilateral ptosis and all that won't fit into this alcoholism. So botulism, when does this occur? Even it can start with the food poisoning and also. Okay. So the patient symptoms of nausea, vomiting, abdominal pain. So this nausea, vomiting, abdominal pain with bilateral ptosis, dilated pupils, and double vision are suggestive of botulism. Rare but serious disease caused by toxins that attacks the nerves, which can lead to difficulty in, eventually it may lead to difficulty in breathing, muscle paralysis, and even death. It is usually associated with consuming improperly preserved or contaminated food. Alcohol intoxication can cause nausea and vomiting, but typically it causes CNS depression, not the pupillary abnormalities and ptosis. Opioid overdose can cause nausea and vomiting, but typically cause CNS depression, respiratory depression, and most importantly, the pinpoint pupils. Botulism, as we already described about this. Cocaine intoxication can also cause pupillary dilatation, but is associated with CNS stimulation and also CVS like tachycardia, hypertension, hyperactivity, which is usually seen, but not we didn't see this in this particular patient. The botulism is a serious illness, Clostridium botulinum, and it may eventually cause difficulty in swallowing or speaking, facial weakness on both the sides, blurred or double vision, drooping eyelids, trouble in breathing, nausea, vomiting, and abdominal cramps. The toxins that can cause botulism came from bacterium Clostridium botulinum. Okay, this is all about. We discussed about CNS, CVS, respiratory, endocrine, questions about the pediatric, OBG, and infectious diseases. So we can take a small break now, and again we'll discuss the rest of the questions after another 15 minutes. Okay.